Our veterans, more than anything, just deserve high quality care and so much, respect, appreciation, and humility for what they've contributed and what they've dedicated to support the country.
One of the things that we do, our mission is to advance evidence-based healthcare globally with a focus on patient safety and equitable healthcare.
Hi everyone, I'm Amanda Pears Kelly. I'm the CEO of Advocates for Community Health, and this is Community Health Centers Unfiltered. This show where we look beyond the headlines and dig into the real people, policies, and innovations shaping community-based care. Today, we're talking about an issue that demands both urgency and compassion: how we care for our nation's veterans. More than half of America's veterans rely on community-based providers for some or all of their health care. And for many, their local community health center is the most accessible, trusted place to get the services they need. But meeting the unique needs of veterans requires more than good intentions. It requires training, coordination, evidence-based practices, and a deep understanding of the experiences veterans carry with them long after their service. That's why I'm so excited about today's guest. We're joined by Shannon Kooker from ECRI, one of the nation's leading organizations committed to advancing patient safety and healthcare quality. Shannon is a nurse, infection preventionist, healthcare quality and safety expert, a military veteran, breast cancer survivor, and brings years of experience helping providers strengthen their systems, improve outcomes, and deliver care that truly honors those who have served. In our conversation, we're going to discuss the gaps veterans often face when navigating non-VA care, the role that health centers can play in bridging those gaps, and the tools and strategies that can help health centers better serve this diverse and historically underserved population. So settle in. This is a really important conversation because when we strengthen care for veterans, we strengthen care for our entire community. Let's get into it. Shannon, it's really nice to be with you today. And to get us started, can you just introduce yourself and tell us a little bit about your work and your background?
Good morning, my name's Shannon, and I'm a nurse. I've been working at ECRI now for about 6 years. And ECRI is a nonprofit patient safety organization. We're headquartered near Philadelphia, Pennsylvania. Prior to coming to ECRI, I actually took care of patients in a hospital in southern Maine. Started my nursing career in Maine. Prior to becoming a nurse, though, I served in the United States Air Force. I enlisted. I became a medical laboratory technician. And that's really where my love of healthcare began, was working in the lab, taking care of patients, having diagnostic testing. Inspired me to get on the other side, to actually be the person delivering the care to the patients. And so I've been in nursing for over 20 something years now. And I'm really fortunate that throughout my career, I've had opportunities to not only care for patients, but also work with healthcare organizations to help them deliver safer care to patients. Currently in my role at ECRI, I lead 5 different teams, including our patient safety organization. We are listed by AHRQ, or the Agency for Healthcare Quality and Research, as a PSO. We have healthcare organizations that we work with, including all of the FQHCs in the country, to help them understand why preventable harm occurs and how we can work with them to identifying those contributing factors so that we can prevent that harm from happening in the future. I also lead our team, our evidence-based practice team here at ECRI. We've done a lot of guideline work for the VA and other organizations. So whenever anyone is trying to develop a evidence-based practice guideline or any resources for clinicians where we're able to evaluate the evidence and make sure that they truly have evidence that's credible, that's driving practice.
That's great. Well, let me start by saying thank you for your service. And I would say also thank you for leaning into the population, because I think it's a really important part of the bigger healthcare picture, but also a population that, from a healthcare perspective, is vitally important that we care for with intention and thought, but I think also is often overlooked. And so that's part of why I was so looking forward to having this conversation today. And would you just go a little bit deeper about how did ECRI start and what is this story, and sort of connect the dots for us in terms of the journey that has brought you to today?
Yeah, absolutely. So ECRI is, as I mentioned, a nonprofit organization. We've actually been around for close to 60 years. So for a long time, we were founded by Dr. Joel Noble, who was a physician in the Philadelphia area. And Dr. Noble was caring for a patient one day, and the patient went into cardiac arrest. And when he went to try to resuscitate the patient, the equipment that he used actually failed. And at that time, he found that, of course, to be unacceptable, how a post-market device that's intended to save a life would do just the opposite. So he, at that point in time, he really committed the rest of his career and life to patient safety. And he formed ECRI, but back then it was known as the Emergency Care Research Institute. So that's where the ECRI comes in. And he, actually built ECRI with his own two hands. And he had got some of his biomedical engineering colleagues to join him. And they built a lab, a testing laboratory. And he said to healthcare providers around the country, send us your equipment and we will test it for you to make sure that it works as intended. We have, that was 60 years ago. We've grown a lot since then. We're still the largest independent device testing lab in the United States. We say that we are independent and we are unbiased. We are not affiliated with any manufacturers, so that when people send us their equipment, they know that they're going to actually have a unbiased assessment of that. And we're going to tell you how it really works under real world conditions. Now, we've branched out from the device testing lab into patient safety. As I mentioned, we're also a patient safety organization, and we have over 8.5 million preventable harm events in our database. And so I always like to tell people that 8 million events, that's a big number, but that's also, moms and dads and neighbors and daughters that have all experienced harm in healthcare. So we take that data very seriously. And one of the things that we do, our mission is to advance evidence-based healthcare globally with a focus on patient safety and equitable healthcare. And so with that mission, we really look to understand where disparities in care are. And I think when most people think about healthcare disparities, they might think about race or ethnicity or payer type. But I would challenge people to think about veteran status as well. I think a lot of people make an assumption that most veterans get their care from the VA, which is not true. There's, over 20 million veterans in the United States, and only about half of them actually get their care from the VA. I'm a veteran. I don't get my care from the VA. So when you have half of the population seeking their care outside of the VA, then we really need to understand, is that care that we're delivering equitable? And I'll tell you just a little bit of a story that will kind of it'll end up really illustrating why ECRI took this on. So when I was 42, I was diagnosed with breast cancer. And it turns out I had triple negative breast cancer. So it wasn't hormone driven. For triple negative, they really don't know what the cause is, but it occurs in younger women. Women of color have a higher risks of triple negative. And a lot of women that serve in the military are diagnosed with triple negative. During my journey, of course, I started doing a lot of research. How could this happen to me? My genetic tests were all negative. I did not serve around burn pits, so I did not feel like I had a higher risk of being exposed when I was in the military, but it still was part of the conversation that I wanted to have. Because I don't have any service-related disabilities or service-connected disabilities, I'm able to get my care from my local community hospital. I've always been very lucky to have good employee health insurance, so I can get my care outside the VA. And when I was going through this journey with breast cancer, when I checked in for a test one day, the person at the admin desk asked me if I had served, and I said yes. And she said, well, thank you for your service. That information never made its way into the hands of my healthcare providers. Throughout my journey, no one ever asked me, have you served? Where did you serve? What did you do? What were your risks? It was never explored. And it really just opened my eyes to the disparities in care that veterans that seek healthcare outside of the VA may encounter. And so I brought this back to my leadership at ECRI. And I said, I know we talk a lot about healthcare disparities, but I really think that veteran care is something that should be focused on. And of course, they wholeheartedly agreed. We started our journey by doing a couple of webinars on, Veterans Day and some other events. And then we just saw this interest, and we had all these people starting to show up saying, that happened to me too. That's part of what drives my passion around veteran health. And so we said, how can we make a bigger difference in veteran health? And so we created the Salute program. And Salute program is a completely free program that we have. It's a compilation of resources, and the goal is to build rapport between veterans and healthcare providers. And I'm really proud of Salute. We have an honor roll of organizations that belong to Salute, including many FQHCs, primary care associations, hospitals, universities, colleges, you name it. And it's going on almost 2 years now that we've been doing our Salute work, and we're just really proud of it. And I'm really proud that ECRI has brought veteran health really to the forefront when we think about healthcare disparities and health equity.
It's amazing, and it's so important. Honestly, it aligns. So for me, I have been really privileged to work with health centers since 2005, and for the entire time that I've been working with health centers, cultural competence is literally one of the required elements, obviously, of the work that they do and the sort of model. But it's interesting because I think you're right. When we think about cultural competence, we're not necessarily thinking about, did someone serve and what does that look like for veterans? However, over the course of time, especially, I was mentioning to a colleague of mine that I've seen it over and over again where whether there's a provider there who maybe is a veteran themselves, or there is an organization who really has gone above and beyond because there's a large veteran population, where then it's sort of word of mouth, where the veteran community ends up really seeking care from that place because they know there is going to be that cultural competence and sensitivity. So I give you so much support and accolades around thinking about how do you equip providers and different types of healthcare organizations to do that properly. I'd love it if you could lean in a little bit more, though. Tell us about what exactly it looks like for veterans in terms of the challenges that they face and sort of what does it look like in community settings and sort of some of the disparities. I don't know if you have data around that or just, I think painting that picture a little bit more in a little bit more detail would be helpful.
Yeah, absolutely. And, I think when you're talking about delivering equitable, excellent care to a patient population, that doesn't just happen by chance. You look at some of these organizations, and I have some examples of some health centers that have done really outstanding work. It doesn't happen by chance. It is designed that way. And, you may have heard healthcare talked about as this socio-technical system, right? And a lot of work has been put into helping to make healthcare better and safer over the decades. And, a lot of people will compare healthcare to other high-risk industries like aviation, for example, and saying, well, you have to design the system. But the issue with healthcare is that we are humans caring for humans with technology. So it's not as easy as a checklist. It really is about understanding the system in which we deliver that care. And when you talk about veterans, you have to look at it through a different lens. When you think about the physical environment of a health center, veterans who have PTSD, they may not be comfortable with a door to their back. When you talk about you just mentioned yourself, engaging employees around veteran health, it makes sense to ask, do we have any veterans that are clinicians, that are champions? So it's really thinking about the entire system in which we deliver care. Now, certainly when you're thinking about opportunities to improve veteran care in any kind of health setting, but, even in a community health center, it's really important to understand the perspective of the veteran. And like you said, some of those challenges that they may experience. And there's many, right? There's many hurdles to overcome here, from enrollment and eligibility, which can be a primary barrier to many veterans, particularly during that transition from active duty or even when they're, not just perhaps getting out of the military, but retiring or whatever it may be. But it's overwhelming and scary to navigate that system of enrolling and then understanding all of the different rules. There's a lot of stigma associated with being veteran. I think a lot of people, I was actually just on a call earlier today talking to some folks that are doing some really great veteran health work, and just saying how a lot of healthcare providers are afraid to ask the question, have you served? Because they feel like they may, offend the veteran. Some veterans will not speak up and say, yes, I served, because of the stigma they may feel that might bring upon them. And then the third major barrier, I would say, is definitely around social determinants of health. There's transportation and housing and employment. All of these factors can create really overwhelming challenges for veterans when they're trying to seek healthcare, or whether it's, physical or mental. And I think, as on the other side of this, as a healthcare provider, particularly in that community setting, it's important that we, number one, acknowledge that there's a lot of challenges that perhaps our other populations may not face. But then number two, really get at it from almost an assessment standpoint to say, how are we equipped to be able to help facilitate veterans to overcome some of these challenges? And I think, I give kudos to, having this conversation today, for you all bringing this up, for all the health centers. I mean, there's so many that are doing really, really outstanding work in this space. I think the more that we talk about it, not just the good things, but also the challenges and the difficulty getting there, because we don't want anyone to think this is an easy journey to be able to create that environment. It takes a lot of thought, a lot of resources, and it takes a lot of leadership support to get there.
Yeah, 100%. I'm excited to get into the details around some of the models and the examples that you see at health centers. Before we even go there, though, Shannon, and you began to get into this a little bit, but I think it is worth talking a little bit more about, like, what does it actually look like in terms of the things that are unique from a clinical and a behavioral health perspective, in terms of the needs of veterans, and what health centers and others need to be aware of as they're sort of beginning to do this work. And just, again, to your point, like, perfect example of something you said earlier, where they may not want to have the door behind them, if you're somebody with PTSD, and that's not going to be first nature for a lot of providers who have traditional clinical training, but haven't necessarily, had to work with this population. So can you talk a little bit more about that?
Yeah, absolutely. When we think about unique service-related health risks, there's generally two ways to look at it. You have the physical health risks, and that can be, just wear and tear on the body, muscular skeletal issues, traumatic brain injury, lots of the different physical things that can be exhibited. But of course, a lot of the focus is on the mental health piece. And certainly we know that veterans have higher rates of PTSD, substance use disorders, moral injury is something that not a lot of people talk about, but we're hearing of more and more. And in the treatments for a lot of these things are complex. And so from a clinical standpoint, or even an operational standpoint, within a community health center or any care setting, understanding what are those risk factors that veterans are going to present with is really important. We know that studies show that at least 1 in 4 veterans will have some kind of mental health disorder, or a physical disorder, or injury when they're separating from the military. So you can, pretty much plan for, when you're assessing veterans, to start to get your mind right in thinking about what are some of those health risks that they may walk through your door with. The mental health piece, and I just want to stay on that for just a moment too. Another gender disparity is that a lot of people, they assume that, a male veteran may have a higher rate of mental health issues, where actually the reverse is opposite. We're seeing more and more data coming out now that's showing that women veterans have higher rates of depression, higher rates of PTSD, and higher rates of suicide. I think having clinicians be comfortable with starting to have some of those conversations, be comfortable with using some of the tools that are out there. There's some really great work that's been done by other organizations, published in the guidelines, that clinicians within health centers can use. They don't have to reinvent the wheel. There are assessment tools. There's a depression screening, suicide risk screening tools that are established that are relatively easy to use. I would say the more difficult part is what to do next when you have those conversations with veterans and you identify that this veteran, man or woman, might be at a higher risk of depression, maybe at a higher risk of suicide. What are then the resources that you can connect them to? What are the referrals that you have to make? I think that's where a lot of the care coordination comes into place. And that's where we see oftentimes a lot of stumbling blocks for the clinicians that are trying to provide care.
Yeah, it's interesting. So, it's a little bit of a sidebar for me, Shannon. I have the privilege of wearing 2 different hats. And so one of my other hats, I'm the CEO for the Association of Clinicians for the Underserved. And at ACU, we actually have a program called Suicide Safer Care, and it is specifically to train primary care providers around what to do next. It's sort of the amount of training when you're going through your clinical training for suicide prevention and just all of it is so limited. And so what we've found over the course of years of doing this work is that a lot of providers just don't feel equipped. It's not that they're not doing the screenings, but to your point, it's sort of what happens next. And, by no means are they the one that are charged with, becoming the primary point of contact or in the mental and behavioral health space. However, there's certain language, and even just doing the training, providing the resources. And so Suicide Safer Care has been a tremendously impactful program just to help primary care providers to gain that extra support and do that training. But I would venture to say that there's another layer, and I'm excited to do some follow-up. There's another layer specifically for veterans in this space. And it's also really fascinating to hear you say the disparities or sort of the data around gender, and sort of the assumptions that are made, whether it's men or women in this space. I think end of the day, it's just our veterans, everyone, but certainly our veterans more than anything, just deserve high quality care and so much, respect, appreciation, and humility for what they've contributed and what they've dedicated to support the country. So I just, like I said, when I hear some of the unfortunate stories in this space, it breaks my heart. But the work that you're doing and the conversation that we're having gives me great hope and appreciation for how much more can be done and that it's working. And so with that, let me take us to, I'd love for you to speak to just examples that you see within the health center community of, where it's going well and sort of programming that's been built in order to address this and just, thoughts on that front.
Yeah. So, as part of our Salute program, we talk a lot about engaging the veteran and then engaging the provider. And a couple of the tools that we've used, we've actually adapted them from the ARC Engaging Patients and Families Toolkit for Diagnostic Safety, which is a fantastic free toolkit out there if anybody's interested. We took these tools. The patient-facing tool is called the Be the Expert on You tool. And it's designed to be given to a patient prior to their visit. And it really helps to get them thinking about some of the things they want to share with their provider. You've probably heard of white coat syndrome, which is true, right? A lot of times, any of us can get in front of a doctor or a nurse, and sometimes we freeze up, we forget all those questions we had, those things that we wanted to tell them. And so we're prompting the veteran to share, when and where did you serve? What was your job while you served? Were you exposed to any toxic exposures like burn pits or Agent Orange? And so we try to prepare the veterans to have those conversations. So that's one tool. And the other tool is for the providers. And we talk about really developing your empathetic listening skills. And it's funny, whenever I talk to providers, healthcare providers, about being a good listener, most healthcare providers, we think, oh, we're great listeners, right? That's all we do. We're trained to listen. When in reality, we are trained to assess and then form a response and then, diagnose and treat. When you're talking to a veteran, we want people to listen in a different way and listen for cues. And so we talk about how to take 60 seconds to listen. But we have these different tools. And what's really exciting is that we've seen health centers begin to use these tools and tie them to other initiatives that they have. So I'll give you an example. And actually, I picked this one special for our conversation today. In Maine.
Love it.
In Maine, the Maine Medical Association Center for Quality Improvement, they won funding in 2023 from the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant. So they won funding for that, and they created a suicide prevention toolkit. And the toolkit was really designed to be used in community health centers. It was designed to enable staff members that are working it could be really in a rural location or in a more populated location, but it's to help have those conversations with veterans as they're coming in. Talks about how to do a depression screening. If the depression screen is positive, then it talks about the suicide screening, but then it also connects them to local resources in Maine. I know they collaborated with the Maine Bureau of Veterans Health, the National Alliance on Mental Health, and they also pulled in some other organizations like the Health Affiliates Maine, the Maine Crisis Line, Maine VA. This toolkit, which has been disseminated out to all of the clinics or the centers in Maine, has also been highlighted on a national level as well. They've been featured on many different national programs, and we've had lots of different states that have asked for it, so we've been able to disseminate it. But what I really liked about this was they created something pretty simple, but it's that combination of engaging the veteran and also empowering the healthcare clinicians to have those conversations. That's one example. I want to share another example from near where I live here in Pennsylvania, Adagio Health, which is a women's health clinic, actually a group of health centers out in Pennsylvania, Western Pennsylvania. They took a really unique approach. They serve West Virginia and Pennsylvania. They started to see several years ago that they had increasing numbers of women veteran that they were serving. And a lot of these women were struggling with not just reproductive issues, but also mental health issues, and just general wellness. And so what they did was they actually worked with the RAND Corporation, which is a group that does research. And they did a really in-depth study, a needs assessment around the women that they serve, as well as the services that they offered. And I think this is really unique because, number one, you don't see a lot of organizations that invest time and resources into truly analyzing at this level the type of needs that their population has. So they took the results of the RAND study and they actually they transformed the way that they deliver care. Some of the really impressive work that they've done, they formed just community engagements and partnerships across Pennsylvania and West Virginia with other organizations to help provide free care to women veterans. They have a specialized care navigation program. And so they actually have a veteran who works for them, who is their women's veteran care navigator. They have nutrition and wellness programs. And one of the more unique programs that they have, which I just love this one so much, is that they did it's called I Am Not Invisible. And it's a photo exhibit. And they were able to highlight women, patients, veterans, and through highlighting their photos, tell their stories of what their experiences were when they served, but also how that experience has really informed their life since they got out. It's just a really powerful story. But again, a comparison and contrast of two different organizations that serve people in the community, how they really were able to identify what the needs are of their patient populations that are veterans and create resources that are tangible, that are pragmatic, able to be applied, and also reproducible, which I think is really important because certainly there's, community health centers, FQHCs, hospitals around this country that are, stuck right now thinking, gosh, we have these veterans, there's an opportunity for us to help. But, where do we get started?
Right. So I love that we're having this conversation and I'm smiling because one, it's great to hear about those two models. But there's another piece to it, which to me, it's like, this is so aligned and foundational to health centers. Part of a couple things that you're saying really jump out at me. One, the importance of engaging the patient. And in this case, veterans specifically, like giving them a voice in how to design a program that is actually going to serve them. And functionally, Shannon, I mean, I'm sure you know this from all the years of working with community health centers, but the consumer majority board exists for that reason. It basically is to say, look, the people and the community that we're serving need to be a part of the governance and the design of the organization in order for this to be successful. So, kudos to Jack Geiger and Count Gibson when they, designed the program with that in mind and all of the incredible wisdom that they had. But I think the other piece is the partnership, is that health centers are incredible and they have all of these unique capabilities in terms of the cultural competence and the providers they have and all of it. But they are not the only organization doing good work, and they are not the only stakeholder in the community to help further what is actually needed and respond to what's actually needed. And so I think the importance of partnerships that comes up in both those models is also really important. And I think, often by necessity, again, that's something that we see with health centers over and over and over again, because they can't be everything to everyone, but also just with the intention to be so committed and to fulfill mission, to make sure that they're working with literally any partner they can to be able to accomplish that. But I think the unique needs and the importance of what this looks like for veterans specifically is really important, and something that doesn't get talked about enough. And so again, that's part of my excitement for the conversation today. And I think, leaning into the partnership conversation a little bit more, both of those examples were really helpful, because I think you called out, in Pennsylvania, that it was a lot. It was an array of partners that were participating in order to forward that. And then there were a couple of key partners in the main example. But I would say in general, or my question for you, in general, are there specific partners that you would call out for health centers to think of or lean into off the bat, to sort of, if they want to do more in this space and sort of build some of this programming, are there key partners that they should start with or think of first?
Yeah, I would, I think a couple of groups that come to mind would be the offices of rural health. We know that there are higher percentages of veterans that seek care outside of the VA in rural areas. And so they make really wonderful partners. They often missions are aligned, particularly when it comes to funding and policy development, they're great partners. And also primary care associations. Yeah. I think primary care associations can really provide that leadership. There's strength in numbers for sure, advocacy, and connections to some of the government and both state and federal agencies that can help support. So I think by having alignment with those types of groups, also there's veteran service organizations out there, both local, regional, and federal, that again, are aligned in a lot of the objectives and missions. It really is about building the partnerships, and it doesn't happen overnight. I think you have to really be strategic in this work. I think having a plan for how you want to expand your veteran health capabilities is really important. I think having buy-in from the board all the way down to your frontline clinicians that are caring for the patients is important. And again, I said at the top of our time here that this doesn't happen by chance. It's really an approach that requires system redesign. We have an assessment tool that we give to our Salute program teams, and it talks about how to assess for your physical environment, your tasks and processes, your technology, but then your organization. And it says, what are some of the things from an organizational level you want to assess for? Do you have a veteran that sits on your board? If you have a patient and family advisory council, do you have a veteran that sits on that? Do you have partnerships with local nursing schools or medical schools? There's some fantastic work going on in some of these schools, particularly in more rural areas, because they know that they need to really improve that cultural competency of healthcare providers that are going to be going out into the community doing primary care. So I think it's a matter of really just doing a needs assessment, understanding who those potential partners are in your space, and then just reaching out and making those connections.
Yeah, I totally agree. Couldn't agree more. I think I want to take us in the direction, I'm thinking about time, but I want to take us in the direction of data and advocacy, or sort of data advocacy and policy, because I know that you guys, ECRI has been really successful in terms of the data you've been able to collect in a lot of these different areas. So let's talk about that. Sort of what does that look like? Is there specific data that you would call out or bring attention to? And then the second piece of the question being, how do we leverage that data to tell this story and help educate policymakers? Because I think, from my perspective, part of the overarching goal of the conversation today, but I think in general, is we do need to have more supportive policies and more resources to support this kind of work. And so, but please, if you would just share a bit on that front.
Yeah. I mean, in terms of the data, we look a lot at, I talked about earlier, preventable harm, right? So what are some of the outcomes of the care that we deliver, and some of those unanticipated outcomes? And I will tell you, especially with veterans, diagnostic safety really rises to the top. And diagnostic errors are probably one of the at least in our data, are one of the top types of harm events that occur, particularly in outpatient care. I think a lot of people tend to think about, harm that occurs in the hospital setting, but when you think about outpatient primary care, diagnostic care, diagnostic errors really rise to the top. And when you're particularly focused on a population that has some of those unique health risks, like veterans, it can be challenging for clinicians to, number one, make accurate assessments, but then, make what type of diagnostic testing should be used, interpreting that testing, and then making that follow through. So I think from a data perspective, that's one of the areas that we've really focused on, is ensuring safe diagnostic care and treatment of veterans. The other piece, as an evidence-based practice center, we've done a lot of guideline work, and we've done work for the VA and the DoD, and helping to establish evidence-based clinical guidelines for clinicians not only in the VA but also outside of the VA. And part of that is analyzing evidence that truly does support care that is relevant, that is clinically sound. And so, I think we would advocate that organizations, when they are adopting certain guidelines or practices, that they use sound sources. Not promoting the VA guidelines, but we do think they are well done, and that way, when you're delivering that care, it is evidence-based. I think, the other area that we've done a lot of work around is rural health. And we recently did some work analyzing the structural measures in place for community and critical access hospitals, particularly around patient and family advisory councils, ways to engage patients and families in being able to comfortably report incidents or harm events when they occur. And we know that healthcare organizations in rural areas do have a more difficult time establishing some of these structures. Now, when you think about policy, right now there's a big focus on rural health. And there's a lot of money that's going to be flowing from the federal government to states in the next couple of months to help support infrastructure for rural health. We have talked to some states that are also including a focus on veteran health as part of this, which is really important because funding and policy can help improve, I think, a lot of different things. I think it can help improve access to care. I think it can help organizations that perhaps didn't have the resources before to explore more innovative solutions like telemedicine, remote monitoring, even more some of the hub and spoke models where you may have physicians that are in high demand specialties that are able to learn from each other, particularly in some of these more remote and rural areas. So, I would say from a policy standpoint, if there are folks listening today that are wondering what can we do, I would say start with the data. HRSA has a lot of data. There's a lot of data that's out there. Really understand where some of those disparities are in veteran care, particularly those veterans that are seen at the community health centers. Start to examine some of the differences in care between the care that's delivered in the community and compared to what's delivered in the VA. Now we know that there is the community care program that's been established for a long time. I know many of the FQHCs belong to that program, which is wonderful. But there are differences there. There's differences in what the VA does and what the expectations are in some of those community health centers and those community settings. So I think it's important for policymakers to be able to understand what are some of the differences, where are the opportunities to improve the quality of care in the community compared to the VA, and then what resources are going to be needed to really help get them there. And then the final piece I would say is to understand the perspective of the care from the veteran. We certainly focus a lot in our country in healthcare around patient experience. If any of us have been to a doctor's appointment or even, maybe any kind of healthcare facility, the hospital, or even, an endoscopy center, anywhere, you normally get a little survey afterwards. You might be a phone call, it might be an email, but they want to know about your experience. I think it's really important that we survey the veterans' experience in different care settings. I think we're going to hear more in the future it's going to inform policy around patient-reported outcomes. And this is different than patient experience. This isn't so much, rate your likelihood of using this center, but it's more, did the center effectively assess your unique service-related health needs? Did your clinicians address your mental health concerns? Did they collaborate with you on a holistic plan? Did they address some of your challenges that you've experienced during your transition from military to civilian life? These are outcomes that are not related to lab tests or x-rays. These are real world outcomes that we're getting from the veterans that are really powerful. And I think when we start to hear the voice of the customer, the voice of the patient, the voice of the veteran, these are stories that our leaders, our clinicians, our policymakers can then take back and say, are we hitting the mark?
Yep.
Right? Or do we still have work to do? I think those are all powerful things. So, inform from data, inform from experience, and then also look at are we meeting the standard of care that's expected?
Again, I couldn't say it better myself. One final question for you, Shannon. So if there's one thing that you would want for health center leaders to know and think about or sort of walk away with based on our conversation today, or just sort of what they can do going forward, what would that be?
Well, the first thing is find a way to ask the question, have you served? Right. And I know there's been some great work done about standardizing this question in health centers. So keep asking that question, have you served? Next, figure out a way to engage veterans as partners in care. And, we've mentioned a couple of tools in our discussion today. We've given a couple of examples, but talk to veterans, understand what they need from this care, and really treat them truly as partners. And then finally, take the time to create a culture among that team in which they appreciate the work that they are truly doing. When you're caring for veterans, you truly are serving those that have served. And as leaders, I think it's really important that we're able to model that behavior for our team members, right? There's an old saying that says, culturally strategy for breakfast. And it's really true. You need to have your strategy, but you also need to be able to grow that culture within your center, your organization, your network that truly understands that veterans have unique health risks and that you are going to resource your teams so that they can be equipped to be able to take those challenges on head on.
Shannon, honestly, I can't thank you enough. I want to thank you again for your service, but just so appreciate the work that you're doing. And hopefully this will be the first of a few conversations, honestly, because I think that there's more to talk about and just the work continues. But thank you for joining us today, Shannon Kooker with ECRI. For those of you who are able to join us, I hope you enjoyed the conversation and would invite you to join us again for our next conversation on Community Health Centers Unfiltered. But Shannon, again, thank you so much for joining us today and for all the incredible work that you're doing. Very grateful.
Thank you for having me.
Thanks.